Good morning, everyone. Welcome to another episode of the Practice Perfect podcast. We have an amazing guest on the show today. We want to welcome to the stage our amazing guest, Sanal Patel, and of course, our amazing co-host, Maya Turner. Hello, ladies. How are you today?
Good
Hello.
morning.
Good morning.
And all tech issues aside, we hope that you can hear us and see us, and we're going to have a good discussion today. If you missed anything we say, we'll try our best to answer questions in the chat. You can chat with us live, ask your questions. We have an amazing, amazing resource with us today in Sanal Patel. And we want to talk about something that, I don't often talk about because I don't work in behavioral health. I think I dabbled in the credentialing side of it many moons ago, but not something that I do all the time. But I'm excited to talk about a specific thing today, compliance in behavioral health, which is a big deal, right? I mean, Sanal, what are some of the things you see that are just compliance concerns in behavioral health these days?
Yeah, well, first of all, thank you so much for having me on today. I'm honored to support you. But, in terms of behavioral health, yeah, I'm sort of inundated with auditing. And there have been so many issues since the beginning of the year, right? And we're already halfway through the year. Well, we're in month 7, right? And there has been just endless amounts of continued misunderstanding with documentation to support those build codes that are going out to the insurance carriers. And so the issues are mostly the same when it comes to psychotherapy documentation. That's always been on the hit list for SIUs, for the commercial payers, as well as for the OIG on the government side, right? But when it comes to telehealth, that also throws another wrench into the mix. So that really does prove to be another compliance risk that I continue to see. And our providers, even though the pandemic is long over, right, Maya, there's still so much that our providers aren't getting right in terms of
Yeah.
documentation for telehealth. And
Yes.
it's still a requirement that things are documented. Are you talking on the phone with the patient? Why? Is there no two-way audio video, right? So all of these small things can, of course, in a payer's eyes, end up in a overpayment if that claim was originally paid, right? So there's lots to consider in the landscape for 2025. In my opinion, based on what I see, there's so many opportunities for things to go sideways when it's not just psychotherapy now, right? It's psychotherapy with the telehealth,
Yes.
platform. So it just causes havoc.
Yeah, and I could
Understood.
actually
Now, I mean,
that.
yeah, go ahead, Maya.
No, I was just going to say I was involved with a case where it was involving refugees and psychotherapy,
Mhm.
and because of the the sensitivity that's associated with the refugees and the care, you have to think about what their mental health status is and how the state is trying to supplement those types of programs. And I was involved in a case where they didn't like it very much. And when I reviewed the notes, they didn't have any time. But again, you have to think about what all they are doing. They're not only supporting them mentally, they're helping them do a lot. They're almost like the caseworker, but only getting paid for being the social worker. And it was just insane about how granulated the case was. But when I reviewed the notes, you saw everything that they were doing. You saw the level of services that they were doing. They were well beyond the scope. but the only thing that they could really get paid for was a psychotherapy. And so you really have to think about the sensitive landscape of the refugees that come in, the ICE agents that are coming in, and how that plays a toll. And not to get politically inundated in this conversation, but we really need to start thinking about um, the elements that are associated with how psychotherapy is coming into play and what type of resources that are needed, and how, like you say, Sanal, the platforms that are being used, what's being documented, and if it's done the right way to even get paid for the services that they did do. So it really is um, it's a big to do, and it's a big cloud that's going to always hang over us until
Mm.
this public, uh, I don't want to say democracy, but it really is of um, the way that our refugees are being treated. I mean, and it's just something that we all need to bring to the forefront, because it's all affecting us, whether we think so or not. Of seeing it, people being taken out of schools, how the kids are coming home talking about it. So I didn't mean to go off keel, Jennifer, but it's just really a very sensitive subject, and I
Yeah.
think it's something we need to bring to the forefront, and really kind of talk about the psychotherapy piece and how this translates to compliance, and for people to get paid for what they are doing. That's within scope.
And it's all about, we talk about access, we talk about, resources. And when I'm talking to providers, even in different things I'm trying to understand, I'm always looking at the why behind something. So I always like to look behind and say, okay, this rule exists. Why did they create this? What is the reason behind it? And then try to explain that to my providers, my physicians, mid-level or non-physician practitioners. Like, this is the rule. This is why it exists. And we just want to make sure that obviously your patients are taken care of. And, we talk about documentation, that it's not just a reimbursement tool. Like, it's not just, it doesn't exist just to get paid. It is a legal document. So you want what really happened with your patient to be represented correct. And the next physician that's seeing your patient, they also want to know what the patient's been going through so they can provide assistance to the patient, because it's all about the patient, right? At the end of the day, that's why we exist, is for the patient, right?
Absolutely. Yeah.
So that's what we're up against. And we want to talk about the why, right? The why behind the visit. We need to understand the telehealth aspect and the rules, because again, you're practicing medicine. This is one of the things I think that we still see, is where they're trying to do telehealth in different states, still a thing. And recently I did present for NAMUS on some of the non-physician practitioner things that we see with credentialing and just different things. And when I do credentialing, that's one of the things we look at is the state laws. Are you licensed to practice medicine in this state that you're going to see the patient in, or where the patient is? And so let's talk about that for a minute. Like, what are we seeing there? Are physicians still confused about that you're seeing?
Absolutely. I definitely have seen in the audits that I'm doing, there are nurses that are coming in and I only see a credential or a licensure from one state, but the practice that I'm reviewing is in a different one, right? So there's a lot more back end research from an audit perspective that has to take place, right? So yeah, I think there are still a lot of considerable issues on what can be performed across state lines and by whom, because the payer is going to want to make sure that things are buttoned up. Right. So from an education, a proactive education approach, we really have to step in when we work with our practices and make sure that they have a internal roster and someone is, the head of taking charge of, making sure that their licenses are up to date, what states, where they're allowed to practice, etc. Right? So a lot of that proactive approach has to take place because of this new platform that was identified. Well, it was here in the late 60s, but of course we didn't start to use the telehealth platform the way we do now post-pandemic, right? Everything was introduced and we were all learning the whole system. Every third day, the rules would change, right? But we're long past the pandemic and things are more fixed. But we still have to help.
Almost.
Almost, right? Yeah, exactly. We still have to help our providers understand how they can do things correctly so they can, protect their reimbursement. But I love what you had stated, Jen, because absolutely the patient record is the key, right? It's the patient care. And that documentation is for a legal purpose. It's that care coordination. Where are they going to go
Yeah.
after their psychotherapy session, for example, right? Are they going to have to be hospitalized? Do they have to be transferred to a more inpatient, place of service, etc.? So multiple eyes and caretakers are going to be looking at our records, right? So we have to make sure that those patient stories are clearly painted for the next provider to understand. It cannot be so discombobulated. And I know we're going to hit up the EMR systems soon in our
Yes, we
conversation.
are.
Huge issue, right?
Absolutely. Absolutely. And yeah, I just want to highlight that. And so on the credentialing side, because we credential hospitals, and so there's a very different dynamic when you're looking at what a payer is looking for to enroll a behavioral health provider. We have like the plans themselves that are different, like so United Healthcare or Blue Cross of that area, they would have a specific plan just for behavioral health services. And so knowing how to enroll the provider, the documents you have to have in place. I work with some clinics that when I'm credentialing that it's like, I can't seem to get across why we need certain documents. And so I try to explain, they're going to pay you for services and their name's attached to that payment. So like to them, it's really important that they agree that the provider is allowed to practice medicine. And they don't want to shell out money from their entity saying, I agree with what you're doing if they don't agree with what you're doing. So, I mean, like that is in my head, like logically, if I was paying a bill, I would want to know what I'm paying for.
Yeah.
And so from a payer's perspective, I totally understand why these certain rules exist and why we have to collect certain documents. Because if you don't have an active license in this state, or you don't have that specialty, like that scope of practice in place, you really shouldn't be providing those kind of services.
Absolutely.
So
Yeah.
No, I was just going to say, there's so many caveats, right? And cogs in the wheel when it comes to compliance and telehealth and the rules. I mean, Sonal, you talked about the mid-level practitioner, but we also have to think about the way that they practice in different states and their autonomy in different states. We haven't even brought that into play, right?
Oh yeah.
Then you have to with the licensure. I mean, it's insane about all of these levels of granularity that need to be addressed in the compliance landscape. And, it's just, when we think about the patient care, at the end of the day, it really is about the patient. But then it's about getting paid. Like you're giving away services that you're not going to be able to keep if certain aspects of the medical record aren't up to par, and licensure requirements that people fail to realize by going to the Centers of Connected Policy, Centers of Health Connected Policy.
Yes. I love that place.
Yeah, it's just not, people need to know, and they're not accessing it because they don't know. They don't know what they don't know.
Yeah, there's a reference out there actually that I found. It's older. It's like from 2017 from the American Medical Association. And even though the policies might have changed, it's a really great reference. And it takes you directly to the state website for each state for those rules for the non-physician practitioner. So you follow that specific, heading in the policy, and it tells you, okay, in this state, this is what we have to have for collaboration agreements, or this is what we have to have for, how long, many hours they have to supervise. And there's the supervision thing that we can talk about too is, so now what do you see lately? And like, are they so confused about, I mean, rightly so, because it keeps changing, the supervision requirements
Oh,
that
goodness.
exist in their state? I mean, like, I understand that can be overwhelming to an organization when it's constantly changing, but what are the organizations doing behind the scenes to make sure physicians understand what they're supposed to do in their state? I mean, where are office managers and where are our compliance people making sure physicians know this? They should know it first, first of all.
Absolutely. Yeah. And that's where we see a slight disconnect, right? We really need to be able to go in as an auditor, as a compliance professional, and ask for their compliance manual, right, ladies? Like that should be something that can easily be provided to us, and we can flip to section, 2.3a and look at where that supervision requirement is listed, right? As well as the various changes that were happening, especially for telehealth over these years, right? We always ask that compliance manual is revised, it's
Yeah.
edited, it's changed because healthcare is always changing, right? So, yeah, in terms of our supervision, I'm not sure how I feel about that supervision that is from, far away until the end of this year. I don't really know how I like that in terms of the supervision requirements, right? From the CMS that's going to go away supposedly at the end of this year. But I'm not really sure how that works. If there's internal policies, I have not seen one yet at a particular facility. So I can't really speak to it directly. I wish it was written there. Like we just stated, it should be loud and clear in your compliance programs, your manuals. But again, that
If they have
is
a compliance manual.
If they have one, yes.
right, if they have one.
So big if.
I know. Hopefully one day soon, we will all have one, right? Every provider, every practice, every entity that we work with will have one.
Oh man,
But
I
yes,
hope
the
so.
larger hospitals absolutely do have them.
Yeah, they do.
Absolutely. But it's those smaller to mid-size that, we're not at 100% yet. We're not nearly at 100% of organizations
Yeah, when we
having them.
work with them and we run across one that doesn't know that they need to have that, or they just like, and I've heard Sean Weiss talk about this and the compliance guy in some of their sessions too, is like,
Yeah.
like you have to dust it off because it's in a binder. Like we're in 2025. Like if it's
Yeah.
dusty, that means it hasn't been opened.
Right. It hasn't been edited. It hasn't been looked at. Like no one has, flipped through it. Like this is old.
Like that's like, it's comical to us, but then at the end of the day, it's a serious thing, right? Because, we want to make sure that what's going on. And like, we're a third party, most of us, obviously, all of us here are third parties. And because we're consultants, we aren't working, in the office directly. So they come to us, they want to know what they should do. And we advise them, with disclaimers, of course, that we're doing the best we can to give them accurate information based on what we can find. But at the end of the day, they have to make the decisions, and those decisions need to be based on policy so that everyone knows that they're not just the wild, wild west out there making decisions, that they're based on something.
Right, Jennifer.
In the
Like
policy.
so not like a napkin and a handshake that's put in a drawer agreement for them to do something. So it's just insane how people really don't realize how rules and regulations with compliance and having things in place are important.
Let's take a break, ladies, and let's answer this question from our audience. I love when we get questions. We don't get them super often. This is a great question. Right. If a supervising physician out of the office, like vacation, can the employee, their mid-level or non-physician practitioner, being supervised, remain in the clinic and work under another physician in the practice? This is in Georgia. What do you ladies think? I mean, this is not my area specifically, but love to hear your thoughts.
Yeah, I think when you're dealing with collaborative agreements, depending upon what the specialty is, And Sonal, you can add to this. But usually collaborative agreements, when there's more than one practitioner, it's usually with more than it's the specialty. And
Right.
so when you're dealing with the collaborative agreements and one is on vacation, they still can provide the service based upon the collaborative agreement because typically they're on a roster with
Yep.
physicians
Right.
and it's not specific. Unless they're in different locations, then it becomes a little bit different. But at the end of the day, the collaborative agreement is specifically supposed to be for the practitioners that are in the office. So they can still work with another physician as long as they're part of that collaborative agreement specialty and that they're able to practice with the other physician and still be compliant.
Absolutely.
Yes.
That is spot on and well said. And I would just recommend that our questioner, Cindy C., just make sure that you're always looking at your state statutes as well for support, especially here for the state of Georgia. I don't know off the top of my head,
Right,
but
me
that's
neither.
always best practice to look in the weeds of those state statutes, and you'll get your answers right there.
Yes, absolutely. And then I'm in our show notes. I'm going to put in some of those resources that I find are helpful, that you can go to your actual state. And then the Centers for Connected Health is also obviously great. You can go there. They have a map, which is really awesome. And you can click on your state and it pulls up all the stuff you need to know about supervision and all that kind of stuff for telehealth, but it also is helpful in general for other things. Recently, we were actually doing this project for one of the hospitals we collaborate with, and they wanted to attach their APRNs to several clinics so they can move around, right? And so they have the collaborative agreements. It tells you who the supervising physician is, if there's multiple, and it's based on their specialty, right? In the state of Arkansas, where I reside, they have in their, laws in the requirements what that is for supervision. Like that they can supervise multiple locations as long as it's in their scope of practice. So again, knowing your state, what can those supervising physicians do? Can they do multiple clinics simultaneously as long as it's the same specialty? So knowing that is key.
Yeah, and then also the addresses need to be on the collaborative agreement as well, because a lot of times those are missed. Because if the addresses are not listed there and they're moving around, then you've got some issues because the malpractice location is and the insurance is specific to that location. But if everything that's associated with how that collaborative relationship is, then all of the places of where they practice should be involved if it's in the physician practice. And then the medical staffing requirements, of course, would have when they're practicing in the hospital would also need to have some additional references for their agreements and the staffing requirements there.
Absolutely. Great stuff. Well, let's move along, ladies. Let's talk about EMR templates. Are you ready?
Oh, boy. Okay. Look at our faces. Yes, we're ready.
Now we're like, ooh, here we go. Well, let's just talk about it. Now, I remember back when we were doing this post 2020 in the middle of the smack dab in the middle of the pandemic, I was working in the hospital still as a production coder, but I was also helping on other tasks with my teams. And, telehealth was not my thing. I mean, like I worked in surgery. It was never a thing I ever even had to deal with. And so when our surgeons started to do telehealth, it was just like, what is happening? Because they were not used to it, right? They weren't used to all these requirements. And so we had to have like a matrix, a spreadsheet, like every single day of who does what. And then we were trying to get the templates built, right, in the system because it wasn't built for some specialties at that time. Like they didn't ever have to do it. So it was confusing what you had to include in your template if you were going to use one. So I think that was just in general difficult. The time needs to be there, right? What you did obviously during the services still needs to be there. When there are time codes, you got to have time documented. How much time did you spend? Those things. But what are we seeing now, Sonal, that is an issue? Like what is really supposed to be there? Let's talk about that first. What is supposed to be documented if you're going to use a template for telehealth services right now?
Well, you hit it on the head. I mean, for our psychotherapy, that's just our great example, right? Because it is a time-based code. So nothing has changed. It is still missing time, start time, stop time,
Stop that.
or total time. So you just see a barrage of what the counseling was about, which is wonderful, but there is simply, that large factor that is MIA, which is time. So I still see that as a huge issue. I do not see templates that contain somewhere in the language the consent for the telehealth. However,
Yes.
an auditor on the payer side is going to ask for just another piece of documentation, just consent to treatment, right? A separate piece of paper. It doesn't have to be embedded inside of the EMR, right? Note. So there's various things that you can educate your providers on, that even if you're not, asking for that consent in the session, they have to be able to show the patient before they check in virtually. They need to be provided electronically or via fax. However, they need to be able to provide a signature. They have to read that huge document for their consenting to telehealth, to the janky service, right? They might come in and out like how we are here on StreamYard, right? There's some technical glitches that might happen because it is a two-way audio video session, etc. And then, of course, when it's just an audio only, there are recent changes as of 2025 for the audio only, right, Maya, for consent. It has to be, why is that patient only able to do this service via phone only, right?
Yeah.
So there has to be some sort of logic, like, I don't have a computer. I don't have a two-way. I don't have a smartphone, right? I only have a flip phone. Or your consent could be, well, I don't want to be on camera. Like, I don't want you to see what's going on in the background. I have, a lot of stuff going on. I don't want you to see my face on the camera, etc. Right? So
Or
it just has
something
to be
else.
some kind of a reason,
Yeah.
or something else. Exactly. Some other
I've got some
shenanigans
circus
that are
back
happening.
here. Yeah. But this brings up a previous conversation I had with Christine Hall, which is actually a really cool story. Was that you probably have heard her say this, where the physician was talking to the patient and she noticed in the background it was like a tree in her backyard, and that prompted her to understand why the patient had a specific condition, a rash. And so, like, that was a really good benefit for them having the telehealth, because the
Yeah.
physician was able to diagnose the patient from their home with something that they wouldn't have known otherwise. And so, like, there's a huge benefit to having the camera
Yeah.
on, but there are people that, again, don't want to be seen,
It's
and
Right.
true.
that is
It's
okay.
true.
That's their right.
Right. And I also think, though, when you're dealing with, telehealth, and you're dealing with the older population, the Medicare population, you know, um, there are some technical difficulties with them being on the phone audio real way, or like you say, if they just have a flip phone with no camera, or the camera is really, antiquated.
Mhm.
And so when we think about those types of things, and then we think about the services that being provided, and the doctor fails to document that there was no, um, there were technical issues, because a lot of times they don't do that. And
Right.
it's important, if they start something the same way and it fails, that you can bill it the same way because it started that way. But if they don't document that it was failing, for
That's
them to
right.
still get that same venue of how they started, then it becomes an issue. And I think
Mhm.
a lot of times when you become, involved in the telehealth arena, especially when you're dealing with, behavioral health or what have you, and it fails, and then, we don't know what type of sensitive issue that they're dealing with, or how it's translating to that failure, or if they're choosing to fail because maybe they might be teeing off to a different direction. So I think it's really important, in those respects, to document when it's failing, why it's failing, and that it was resumed for whatever reason, so the provider can continue to get this service that they started with, rather than a telephone, which is a lesser benefit.
100%. Yeah. I
Absolutely.
mean, there's just so many layers to this.
Mhm.
Now, when I'm thinking about just the templates and so, I mean, sometimes templates can be our friend. Sometimes they can work against us when we are not paying attention to what the previous note had said, or carrying it over, right? Like, Maya, you've had this webinar, we've talked about it on the podcast recently about copy and paste. And I've already mentioned things I've seen just in audits of regular in-person visits where it's carrying over information that makes no sense. So I work in orthopedics. So a lot of fractures, guys. So if a physician is seeing a patient for a fracture and it's documented they did it via telehealth, but there's also evidence that they're in the office. Like, I feel like sometimes I see that and it's so confusing. I'm like, this is a template issue because they can't be doing telehealth and in the office to do a fracture. Like, something happened where they carried over this little statement from the previous note that was telehealth and nobody fixed it. So now to the payer, they're gonna be like, so were you telehealth or were you in person? I don't understand. How were you helping them with their reduce their fracture with telehealth? Were they doing it themselves? I don't know. Did you show them on the screen, do this? I mean, like, what did you do? That's just funny to me. It's comical, but it's a problem because it's impossible.
What I find is, I mean, and specifically with behavioral health providers, is they have a lot of questions, but they don't want to hear the answers. So it's just, I find it very interesting because I did a telehealth session for a healthcare trainer leader, and I had a whole lot of psychiatrists and behavioral health. And I was trying to explain to them what was happening and what they needed. Well, can they do it a nurse visit? I'm like, well, it's not really a nurse visit. I mean, are you thinking about, because I think their interpretation of what certain terms are a little bit different, and the why the terms that are in the medical record and for what reason. And that's not just behavioral health, but I'm just speaking of them because this is the platform that we're speaking on today. But I think that there's a lot of translation that is left open that educators and consultancies like us should be able to provide, and they should be able to have a return on investment for having someone come in and say, okay, this is why you need this. This is why, and unravel the string for them and interpret what those things are. Because again, there's so many things that are left out in the open and left for interpretation that they don't know what they don't know. So it becomes more of a problem, in regards to terms, in regards to what's needed. The difference between a telehealth visit versus a visit or a psychotherapy visit, because all of those are synonymous in their platforms or in their practice. So you have a lot of different things that are going on that may be, lost in translation, that need to be addressed, that are not addressed as much as they should.
Absolutely. Right. Yeah, that is spot on, right? Those EMR systems, for the most part, I've only seen less than a handful that are properly built for the behavioral health space. And when I see those EMRs, I applaud them. I'm like, this is great. That means I know someone on your team. It wasn't me, but I helped them find that right person, right? To help them talk to the EMR company and build a proper behavioral health platform for their notes, right? Because absolutely well said, things are lost in translation. They just understand the simple nurse note structure or the MD note structure. It's very, very different in telehealth, very, very different in behavioral health, right? So when you find the right person on your teams to help talk to the EMR people, it can be much more individualized, not so cookie cutter, not so checkboxy. I still unfortunately see behavioral health notes with checkboxes, which are ridiculous. That's not information that's specific to that patient, right? It's just a little, generic little, like less than 8-word statement and then a checkbox, so you're just, squishing the patient down into this tiny little checkbox. So there's just a few things that are checked off, and there's very little opportunity for the behavioral health provider to free text, right? Like we have to understand what is going on with that patient, right? It's much more than just what's those 8 words in that checkbox, right?
Yeah.
So there's many, many other things that our practices can do in communication with EMR vendors. Don't just settle for, the standard of what you purchased. It has to be individualized to
Mhm.
your practice, to your service
I love
lines.
that. That
Yeah.
makes me happy to hear that. I mean, like that's my biggest
Yes.
pet peeve was when people pick an EMR just to save money, or
Yeah.
their buddy recommended it. It worked for me.
Yeah.
And
Right.
like you have to think about your patients and what
Yeah.
what you want to be in there. Some EMR companies are great, but some just don't understand that specialty. And
Yeah.
they're
Yes.
trying to do a one size fits all situation, and it's not
Yeah.
going to work.
Nope.
So specifically behavioral health, you need an EMR that they've taken the time to understand what you do every day, what your
Right.
patients need to have in their medical record, because let's be honest here, it's their record. It doesn't
Yep.
belong to the provider, it belongs to the patient. So think
Right.
about your patient when you're choosing it. Like, what do you need to put in there that they're going to read later and be like, oh, my provider really understands me?
Man, you know what?
Yeah.
And since we're talking about EMRs and the sensitivity of behavioral health, let's talk about breaking the glass, right? And protecting that patient's medical record, that those patients' diagnoses.
Yeah.
And a lot of times when you're using EMRs that do not have that feature,
Mhm.
especially when you're dealing with
Yes.
behavioral health and dealing
Yes.
with sensitive diagnoses, right? That becomes a huge compliance issue because not everybody is supposed to access that record in the manner
Right.
that it's supposed to be publicly accessible. So
Mhm.
when you think
Right.
about those very one-sided, very simple Word docs that are supposed to be EMR specific, and they don't have those security features in place that are really supposed to be to protect the patient's information, especially when
Mhm.
they're dealing with behavioral health, then you got bigger problems. And then you also have compliance issues and even lawsuits if that
Mhm.
patient's record is exposed to the wrong people for the wrong reasons.
100%. Yeah, I mean, it's a
100%.
big deal. Big deal. I think we've kind of just scratched the surface here on the compliance or behavioral health, but I want to thank everybody for joining live, and then thank our wonderful co-host Maya Turner and our guest today, Sanal Patel. Sanal, we want to make sure people know what you're about before we close out today. So, what are you doing these days? Where can people find you? And if they want your services, tell our audience a little bit about what you do and what you're doing now and how you can help them.
Absolutely. So spcollaborative.net is where you guys can find me for my services, any type of auditing, any type of proactive education for providers. Behavioral health, I am big on that, but I also am well-rounded and do surgery, do all of the other things as well. So find me there. I also have a podcast that just dropped this morning, Paint the Medical Picture podcast. And I can't wait to have both of you back on again for me in the months ahead, for my next season is coming up in the fall. So can't wait for that as well. But yeah, please, you guys, reach out to me. Those of you in the audience at SP Collaborative, that is where you can find me and all my
Sanal
services.
Patel Collaborative, SP Collaborative.
Yeah,
Sanal
SP is for Sanal Patel. That's right.
Oh,
Simple,
In case you didn't
what is
figure it out, yeah.
collaborative. I love working with everybody. So yeah,
I
collaborative.
love
Yes.
it. I love it. Well, you've been working with some great people. I know you work with Advise occasionally. You work with
Yes.
NAMUS, like many of
Yep.
us, and
Yep.
at APC occasionally. So, like, yeah, you're everywhere, and we just love it. So maybe
Thank
one day soon, our paths will cross in person. I know it's
I would love
interesting
it again.
because I'm in Chicago every quarter now, and I always
Well,
forget that
let's
you're there.
meet. Let's meet. Let's
Yeah,
meet.
and
Let's make it
so is
happen.
Maya. So is Maya. So it's just kind
Yeah.
of like,
I love
why have we
you.
not
We
done
need to get together. Yes, let's do it.
Yes.
so?
And
We'll
so I
definitely
think
make
Let's
that
do it
Christine is
happen.
live.
in
Let's
the
do
area
this
as well.
live when we're all in Chicago. How about that?
That'd be super fun. Absolutely. Let's plan
Yeah.
that for the fall or the winter or whenever I end up back up
That
there.
sounds perfect.
So, yeah. Well, you guys have a wonderful rest of your week. We enjoyed this session. We will have more details on next week's podcast coming soon. Thank you for joining us and have a wonderful rest of your week. And of course, let's try to get our practices closer to perfect. Thank you guys so much for joining today.